Good evening, everyone. My name is Amjad Midani. I'm just going to be modulating the meeting today. I'm really sorry for the delay. There was a problem for me logging in, and I have a slightly technical difficulty. Our presenter today is Jikku Haniball. Is one of our mentors, and he's from Singapore. So he's, I think he's really 8 hours, I think, ahead of us. So he's early in the morning. Our meeting today is about shoulder arthroplasty, and we are going to discuss all the FRCS related issues regarding that topic. If you have any questions, you just put it on the chat box there on the bottom of your screen. And now I'm just gonna transfer you to Jikku there.
Good evening, everyone. Thank you for the introduction, Amjad. My name is Jikku Haniball. I work as an orthopedic specialist in the hip and knee unit in Tan Tock Seng Hospital, Singapore, which is one of the restructured government hospitals here. Today's exam topic is FRCS exam talk on shoulder arthroplasty. The scope of this talk includes relevant anatomy, the aims of and the technical challenges encountered in shoulder arthroplasty surgeries, pros and cons of different surgical approaches used, different types of arthroplasty options available and its indications, prerequisites and contraindications, complications encountered and their management, and some evidence that can be quoted in the exam. Glenohumeral joint is a multi-axial ball and socket joint allowing movement in all three planes. In contrast to the hip joint, which is the other large ball and socket joint in the human body, glenohumeral joint is shallow and provides large range of motion. This motion comes at the expense of stability, which makes glenohumeral joint the most commonly dislocated joint in the body. Stability of the glenohumeral joint is provided by static and dynamic constraints. Glenohumeral joint stabilizers are one of the most commonly quizzed topics in viva stations in FRCS and trauma examination, and it is highly likely that each one of you during your exam will be asked about it, and you should be able to come up with a structured answer to it. In the arthroplasty scenario, the most important stabilizers are the static bony constraints and the dynamic concavity compression produced by the rotator cuff and the deltoid muscles. With regard to the bony anatomy, the scapula is anteverted 30 degrees in the coronal plane. The glenoid is retroverted 7 degrees to the perpendicular of the scapular plane and demonstrate 5 degrees of superior tilt. And the humeral head is superiorly inclined with a neck shaft angle of 130 degrees, and it is positioned eccentrically 9 mm posterior to the central axis, and it is 30 degrees retroverted to the transepicondylar axis. The cuff function is compared to a suspension bridge model. The subscapularis tendon forms the anterior pillar, and the infraspinatus and the teres minor forms the posterior pillar. And even if there is a tear of the supraspinatus tendon, as long as the pillars of the suspended bridge is intact, the cuff function is maintained. When there is a discontinuity of either end of the pillar, there will be anterior or posterior translation and elevation of the shoulder joint will be compromised. This concept of cuff function should be well understood from the exam point of view. Coming on to the aims of anatomic shoulder arthroplasty, it is to replicate the normal native anatomy, restore the center of rotation, offset and muscle tension, and regaining the lost range of motion. This includes replication of the anatomical parameters that was mentioned before, and any mismatch of these anatomical parameters can alter the center of rotation and eventually lead to failure of the implant. Technical challenges encountered in shoulder arthroplasty include dealing with a rotator cuff deficient arthritic shoulder and one with a deficient glenoid bone stock. Prosthetic replacement of the shoulder joint with the rotator cuff deficiency requires a constrained prosthesis. The lack of cuff to constrain the prosthetic humeral head causes superior migration during the initiation of abduction, resulting in excessive shear forces, causing superior eccentric loading of the glenoid component, also referred to as the rocking horse phenomenon. This will ultimately lead to prosthetic failure. The reverse total shoulder prosthesis was developed to address this need for constraint in the scenario of arthroplasty with rotator cuff deficiency. The prosthesis include two components, one large glenoid hemisphere and a humeral cup which is oriented in the horizontal direction. The implant design transfers the center of rotation of the humerus medially and inferiorly, and in effect lengthens the humerus. The transfer of center of rotation has got three effects. One, it would increase the tension of the deltoid and allow for compression between the humeral socket and the glenosphere, thus stabilizing the prosthetic articulation. Number two, medializing the glenoid center of rotation would allow for enhanced recruitment of the anterior and the posterior deltoid muscle fibers with improved forward elevation and abduction. And number three, the humeral center of rotation, which is located more close to the bone glenosphere junction in case of a reverse shoulder arthroplasty, would decrease the torque and shear generated and reduce the chance of base plate loosening. Despite these clinical improvements, several mechanical problems were observed with this design. High incidence of scapular notching was observed due to the inferior impingement of the humeral cup on the scapular neck. The device is associated with limited external rotation, often requiring muscle transfers for inferiorizing the center of rotation. There is loss of normal deltoid contour, leading not only to cosmetic concern but paradoxically decreased deltoid efficiency. This is due to the altered pull of the deltoid in a mechanically inefficient direction after excessive inferiorizing and medializing the center of rotation. There is also increased risk of acromial stress fracture and brachial plexopathy with reverse shoulder arthroplasty implants. Coming on to the other challenge in shoulder arthroplasty is to how to manage with glenoid bone deficiency. In osteoarthritis, there is local load concentration and progressive glenoid surface deformation, typically causing posterior glenoid wear, resulting in a biconcave glenoid. Surgical strategies in managing glenoid bone defects include eccentric or anterior reaming in case of minimal glenoid dysplasia, bone grafting or metal augment of the defect in conjunction with the placement of the glenoid component, Biologic glenoid resurfacing procedures such as interposition of facial, scapular, or meniscal allograft tissue along with hemiarthroplasty. Coming on to the approaches in shoulder arthroplasty, deltopectoral approach remains the gold standard utility approach in shoulder arthroplasty. Scapular sparing andro-superior approach is a good alternative in reverse shoulder arthroplasty in the setting of rotator cuff arthropathy, as supraspinatus tendon is absent in this condition. It can also be a preferred approach for some surgeons in the setting of a 3 or 4-part proximal humerus fractures, where the greater tuberosity can be retracted posteriorly and superiorly to improve the exposure. Deltopectoral approach is a true internervous and intermuscular approach which reduces bleeding and postoperative pain. Structures at risk in deltopectoral approach are axillary nerve, musculocutaneous nerve, and anterior circumflex humeral artery, but the axillary nerve injury per se is more common with the andro-superior approach. Humeral exposure is considered better with deltopectoral approach, and in andro-superior approach, the frequently results in inadvertent over resection of the humeral head, resulting in a thicker polyethylene component. Deltopectoral approach provides better visualization of the inferior glenoid and better placement of the glenoid component in its inclination and decrease the incidence of scapular notching. But andro-superior approach is considered superior to deltopectoral approach in overall glenoid exposure, with good direct visualization of both anterior and the posterior glenoid margins, improving the sagittal placement of the glenoid component. Thus, inclination of the glenoid is better assessed in deltopectoral approach, and version is considered better assessed in andro-superior approach. A major drawback of deltopectoral approach is that it requires subscapularis tendon to be reflected to get access to the joint. An inadequate or a failed repair can lead to internal rotator weakness and anterior instability. And there are 3 common strategies to manage subscapularis in total shoulder arthroplasty with deltopectoral approach. Number 1 is a tenotomy and tendon-to-tendon repair, which is a valid option when the tendon has adequate quality and excursion. Lesser tuberosity osteotomy, which allows for bone-to-bone healing on repair. And the third, the most commonly used method, is a subperiosteal peel of the attachment of the subscapularis and reattachment with transosseous repair to the bicipital groove. Now coming on to the options available in arthroplasty. Anatomic shoulder arthroplasty is the preferred surgical option in primary osteoarthritis, post-traumatic arthritis and inflammatory arthritis, and stage 4 osteonecrosis of the humeral head with glenoid involvement. A functional rotator cuff or a repairable rotator cuff tear is a prerequisite for anatomic shoulder arthroplasty. And if there is suspected weakness of cuff muscles on examination, order a preoperative MRI to assess the status of the cuff. The glenoid eroded down to the coracoid process is a contraindication for anatomic shoulder arthroplasty. Imaging with the CT scan help in assessing the size and position of the defect and helps in determining the glenoid version. Indications for reverse shoulder arthroplasty include cuff tear arthropathy, andro-superior escape of the humeral head indicating an incompetent coracoacromial arch, in which situation hemiarthroplasty is contraindicated, a massive symptomatic irreparable rotator cuff tear in elderly with pseudoparalysis, 3 or 4-part humeral fractures in elderly where greater tuberosity has poor potential for healing, and in failed arthroplasty when all other options have been exhausted. Reverse shoulder arthroplasty is ideally suited for low functional demand patients with physiological age of more than 70 and sufficient glenoid bone stock for the placement of the glenosphere. A working deltoid muscle and an intact axillary nerve is a prerequisite for reverse shoulder arthroplasty. Hemiarthroplasty is indicated for proximal humeral fractures in elderly not suitable for open reduction internal fixation and osteonecrosis of the humeral head with glenoid sparing, that is early stages of osteonecrosis of the humeral head. It is an alternative option in primary glenoid arthritis with deficient cuff but with an intact coracoacromial ligament to prevent anterosuperior escape of the humeral head, in which case a hemiarthroplasty with a large size humeral head is utilized. Another indication is glenohumeral arthritis with inadequate bone stock for the placement of the glenoid component. Young active patients is a relative indication where there is high chance of early glenoid component using in total shoulder arthroplasty. Neer in 1988 stated in his original paper that, and I quote, "When articular surface of the glenoid is good, results of hemiarthroplasty is similar to that of anatomic shoulder arthroplasty, where on the glenoid was not a problem when the articular surface was good at the time of surgery and glenohumeral motion is re-established." I unquote. Humeral head resurfacing is an attractive option in patients with arthritis associated with proximal humeral deformity that otherwise would require a corrective osteotomy to placement of a stemmed implant, and also in patients with ipsilateral shoulder arthroplasty. Coming on to the common complications, infection rates after shoulder arthroplasty is relatively low, less than 0.5%. It is difficult to identify prosthetic joint infections pre-operatively, as large number of patients with intraoperative cultures do not show abnormality in their preoperative examination and investigation studies. This may be due to high prevalence of slow-growing microorganisms like Propionibacterium acne. Two-stage implantation is the treatment of choice for most deep infections after shoulder arthroplasty. Rate of reinfection after reimplantation is low, but functional results are oftentimes compromised by stiffness and cuff dysfunction. There is a reported 6 times greater risk of infection after reverse shoulder arthroplasty when compared to total shoulder arthroplasty. Infection rates reported at around 3.8%. The rate of instability after shoulder arthroplasty is estimated to be 5%. Anterior instability is associated usually with subscapularis deficiency because of failure or inefficient repair. In the management of anterior instability, direct primary tendon repair is associated with high failure rate, usually requires an allograft augmentation or pectoralis major transfer. Posterior instability is resistant to treatment, and there is a 60% chance of persistent instability in this condition. And most surgeons would favor revising an unstable shoulder arthroplasty to a reverse arthroplasty. Intraoperative fractures are especially common in rheumatoid arthritis when there is coexisting osteopenia, and usually happens when the humerus is externally rotated for exposure. Prevention by careful and extensive soft tissue releases before applying any torsion on the humeral shaft will prevent this complication. Post-surgery humeral shaft periprosthetic fractures may be treated non-surgically if the implant is well fixed and the fracture line is located at or distal to the tip of the processes. Otherwise, surgery is required and may involve internal fixation with circulage, wires, plates, and bone struts, or with or without the revision of the humeral component. Capsular notching is the most common complication observed in reverse shoulder arthroplasty. Implant design factors that can reduce capsular notching include lateralized implant designs, decreasing neck shaft angle from the initial 155 degrees in the original Grumman processes to the current design angle of 135 degrees, inferior eccentricity and inferior tilt of the glenosphere may mitigate adduction and impingement and notching. Now coming on to few evidence that can be quoted in the exam. This study is a systemic review of literature of total shoulder arthroplasty versus hemiarthroplasty for glenohumeral arthritis with long follow-up of minimum 7 years, 18 studies, 1,958 patients with 360 hemiarthroplasty and 142 total shoulder arthroplasty patients. Revision rate was higher in the hemiarthroplasty group when compared to total shoulder arthroplasty. There is statistically significant improved range of movement in flexion, abduction, external rotation in the total shoulder arthroplasty group. Pain score was also better in the total shoulder arthroplasty group. Complications of was slightly higher in the total shoulder arthroplasty group. So the authors concluded that the total shoulder arthroplasty results needs reduced revision rates, better pain scores and range of motion, but a trend to result in more complications. In proximal humerus fracture, there is this meta-analysis published in 2016, meta-analysis of 7 studies comparing hemiarthroplasty with reverse shoulder arthroplasty in proximal humeral fractures. The shoulder score, range of the flexion and abduction and tuberosity healing shows favorable results in favor of reverse shoulder arthroplasty. Only unfavorable results in reverse shoulder arthroplasty when compared to hemiarthroplasty was in range of external rotation. Reverse shoulder, coming on to the PROFER trial, reverse shoulder arthroplasty was not considered a management option in PROFER trial 1, which was published in 2015. And the ongoing PROFER trial 2 compares randomized comparison of reverse shoulder arthroplasty, hemiarthroplasty, and non-surgical care. This study is a more homogeneous study where only acute 3 or 4 part fractures of the proximal humerus are included, and only age group that is considered is over the age of 65. The study started in December 2017 and expected to go on till 2023, with the result expected to be published in 2024. Target participants of 380, and with this study we might have the result on which is better for a proximal humeral fracture management. Thank you.
Thank you very much, Jikku. This was a very, very good and comprehensive talk. I think you covered almost everything about shoulder arthroplasty. And this is, you made a very good points about the focus on something topic related to the FRCS, because our main focus here is FRCS and aspect of this topic. The most important thing is that you covered on the basic science, and I have to emphasize that your basic science is a crucial part, especially the basic science of the normal shoulder, the basic anatomy of the normal shoulder, and then you have to emphasize on the approaches, and you cover that really quite well. Then the basic science between of the total shoulder arthroplasty, and then the pathoanatomy of the rotator cuff and why the rotator cuff is important in stabilizing the shoulder, and then the basic science or the questions of the reverse shoulder, and then you provided a very beautiful evidence. I have one question here from the group here, which Sriram was asking, what is total shoulder replacement in inflammatory arthritis? I presume he meant to say, what are the options?
Okay, so that actually was, I mentioned in the talk. In inflammatory arthritis with reasonably good glenoid bone stock, a anatomic shoulder replacement is the preferred option.
Yeah. Thank you very much. Management option for
a patient have now had a reverse shoulder arthroplasty. And the post-operative, I discovered that the patient, I do iatrogenic axillary nerve palsy. What is the management option in this situation?
Just run.
Right. Yeah, so in case of deltopectoral approach, the axillary nerve injury appears to be more dense. And if you are using a andro-superior approach, it appears to be a partial axillary nerve palsy. So the function might not be that much fully compromised. I am not sure about the the management of axillary nerve injury after as a complication of reverse shoulder arthroplasty. I might have to look up at that.
If I may, based on the standard nerve injuries that you would expect to see in trauma, the question will be: is this a axillary nerve injury which is a neuropraxia type injury versus a direct cut type injury? So you need to have a think about what was the cause of your nerve injury. If you think it's a neuropraxia type injury, it's reasonable to treat this expectantly with the view that this is going to get better. If there's no improvement in symptoms in about 4 to 6 weeks, then you can proceed to nerve conduction study to confirm if this is a complete injury or an incomplete injury and how it is progressing. If you think it's a direct cut and a proper iatrogenic injury, then in that case, you need to have a chat with your plastic service or your peripheral nerve injury service. If it's during the operation cut, in that case, my advice is tag the nerve. You will say in your exam, you do not have microscopy available. You would rather this is being dealt with by a dedicated peripheral nerve injury service. So you'll tag the nerve so the location can be found easily. Carefully document where it is in your office of notes, and then calls and wake up the patient, call your peripheral nerve surgery service if it's in a second different center. If it's in the same center, you can have the patient still asleep while your colleague comes to you in the theater and you have a discussion with them then. In terms of, they will do a direct repair or a nerve graft, depending on how badly damaged it is. Okay? I hope that answers your question, Walid.
Yeah, thank you very much, Juan. I think
Question in the varus stations in adult pathology.
Yeah.
Anatomic shoulder replacement X-ray, then complicated by axillary nerve palsy and its management. That was the question. That's why I asked either anatomic or reverse, and post-operative complicated by axillary palsy.
So the options are, if you got axillary nerve injury with anatomic shoulder replacement and you're going to revise to reverse, then you have to either transfer the pec major or you have to transfer the upper trapezius to replace the function of the deltoid. That is the recent evidence, which is from 2018 May. I will just post the paper for you guys if anyone is interested to see.
thank you very much, Kashif.
Because then is you have to